Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today, under Unit 18, Therapy of Infectious and Parasitic Diseases, we'll talk about Chapter 74, Drug Therapy of Urinary Tract Infections. So, this is a quick chapter, so we'll jump right in. Urinary tract infections, or UTIs, are one of the most common infections encountered today. In the United States, UTIs account for more than 7 million visits to healthcare providers each year. Among sexually active younger women, 25 to 35% develop at least one UTI a year. Among older women in nursing homes, between 30 and 50% have had a bacteriuria at any given time. UTIs occur much less frequently in males, but are more likely to be associated with complications, including septicemia and pyelonephritis. Infections may be limited to bacterial colonization of the urine, or bacteria may invade tissues of the urinary tract. When bacteria invade tissues, characteristic inflammatory syndromes may result, which include urethritis, cystitis, pyelonephritis, and prostatitis. UTIs may be classified according to their location in either the lower urinary tract, such as the bladder and urethra, or the upper urinary tract, including the kidneys. Within this classification scheme, cystitis and urethritis are considered lower tract infections, whereas pyelonephritis is considered an upper tract infection. UTIs are referred to as complicated or uncomplicated. A complicated UTI occurs in both males and females and are associated with some predisposing factors, which include calculi, prostatic hypertrophy, an indwelling catheter, or an impediment to the flow of urine. Uncomplicated UTIs occur primarily in women of childbearing age and are not associated with any particular predisposing factor. Several classes of antibiotics are used to treat UTIs. Among these are sulfonamides, trimethoprim, penicillins, aminoglycosides, cephalosporins, fluoroquinolones, and two urinary tract antiseptics, nitrofurantoin and methenamine. With the exception of urinary tract antiseptics, these drugs are discussed in other chapters. The basic pharmacology of the urinary tract antiseptics are introduced here. So, organisms that cause urinary tract infections. The bacteria that causes a UTI differs between community-associated infections and hospital-associated infections. Most, which is more than 80% of uncomplicated community-associated UTIs are caused by E. coli. Rather, other gram-negative bacilli, Klebsiella pneumoniae and Enterobacter, Proteus, Providencia, and Pseudomonas species are the cause. Gram-positive cocci, especially Staphylococcus saprophyticus, account for 10 to 50% of all community-associated infections. Hospital-associated UTIs are frequently caused by Klebsiella, Proteus, Enterobacter, and Pseudomonas species, Staphylococci, and Enterococci. E. coli is responsible for less than 50% of these infections. Although most UTIs involve only one organism, infection with multiple organisms may occur, especially in a patient with an indwelling catheter, renal stones, or chronic renal abscesses. So, specific urinary tract infections and their treatment. In this section, we consider the characteristics and treatment of major UTIs. Acute cystitis, acute urethral syndrome, acute pyelonephritis, acute bacterial prostatitis, and recurrent UTIs. Most of these can be treated with oral therapy at home. The principal exception is severe pyelonephritis, which requires IV therapy in the hospital. Drugs and dosages for outpatient therapy in non-pregnant women are shown in the following table. So here at table 74.1 is an excellent spot to hit pause. So you can take a look at the regimens for oral therapy of UTI infections in a non-pregnant woman. speaking specifically on acute cystitis. Acute cystitis is a lower UTI that occurs most often in women of childbearing age. Clinical manifestations are dysuria, urinary urgency, urinary frequency, suprapubic discomfort, pyuria, and bacteriuria. It's important to note that many women, about 30% or more, with symptoms of acute cystitis also have asymptomatic upper UTIs. In uncomplicated community-associated cystitis, the principal causative organism is E. coli, again about 80%, S. saprophyticus 11%, and Enterococcus faecalis. For community-associated infections, three types of oral therapy can be employed. There is the single-dose therapy, a short-course therapy, and a conventional therapy. The short-course therapy is usually 3 days and the conventional therapy about 7 days. Single-dose therapy and short-course therapy are recommended only for an uncomplicated, community-associated infection in a woman who is not pregnant and whose symptoms began less than 7 days prior to starting treatment. As a rule, short-course therapy is more effective than a single-dose therapy, and therefore is generally preferred. Advantages of short-course therapy over conventional therapy are the lower cost, greater adherence, fewer side effects, and less potential for promoting emergence of bacterial resistance. Conventional therapy is indicated for all patients who do not meet the criteria for short-course therapy. Among these are males, children, pregnant women, and women with suspected upper tract infections. Several drugs can be used for treatment. For uncomplicated cystitis, trimethoprim, sulfamethoxazole, and nitrofurantoin are the drugs of first choice. In communities where resistance to these drugs exceeds 20%, difluoroquinolines are good alternatives. When adherence is a concern, phosphomycin, which requires just one dose, is a good choice. Beta-lactam antibiotics should be avoided because they are less effective than the alternatives and less well tolerated. Which brings us to the acute, uncomplicated pyelonephritis. Acute, uncomplicated pyelonephritis is an infection of the kidneys. The disorder is common in young children, older adults, and women of childbearing age. Clinical manifestations include fever, chills, severe flank pain, dysuria, urinary frequency, urinary urgency, pyuria, and usually bacteriuria. The E. coli is the causative organism in about 90% of the initial community-associated infections. Mild to moderate infection can be treated again at home with oral antibiotics. Preferred options are the trimethoprim sulfamethoxazole, trimethoprim alone, ciprofloxacin, and levofloxacin. Treatment should last at least 14 days. However, for severe pyelonephritis, it does require hospitalization and IV antibiotics. Again, our options include ciprofloxacin, ceftriaxone, ceftazidime, ampicillin plus gentamicin, and ampicillin/sulbactam. After the infection has been controlled with IV antibiotics, a switch to oral antibiotics ought to be made, usually within 24 to 48 hours. That brings us to complicated urinary tract infections. Complicated UTIs occur in males and females who have a structural or functional abnormality of the urinary tract that predisposes them to developing infections. Such predisposing factors include prostatic hypertrophy, renal calculi, nephrocalcinosis, renal or bladder tumors, ureteric strictures, or an indwelling urethral catheter. Symptoms of complicated UTIs can range anywhere from mild to severe. Some patients even develop systemic illness, manifesting as a fever, bacteremia, and septic shock. The microbiology of complicated UTIs is less predictable than that of uncomplicated UTIs. Although E. coli is a common pathogen, it is by no means the only one. Other possibilities could include Klebsiella, Proteus, Pseudomonas, Enterobacter, Serratia, and even the Candida species, as well as the Staphylococcus aureus. Accordingly, if treatment is to succeed, we must determine the identity and drug sensitivity of the causative organism. To do so, urine for microbiologic testing should be obtained prior to giving any antibiotics. If symptoms are relatively mild, treatment should wait until test results are available. However, if symptoms are severe, immediate treatment with a broad spectrum antibiotic may be instituted. After test results are known, drugs specific to the pathogen can be substituted. Duration of treatment still needs to range from 7 days for cystitis to 14 days for pyelonephritis, or when there is a systemic involvement. Which brings us to the recurrent urinary tract infection. Recurrent UTIs result from a relapse or reinfection. Relapse is caused by the recolonization with the same organism responsible for the initial infection. In contrast, reinfection is caused by a colonization with a different or new organism. So, speaking first on reinfection. More than 80% of recurrent UTIs in females are due to a reinfection. These usually involve the lower urinary tract and may be related to sexual intercourse or the use of contraceptive diaphragm. If reinfections are infrequent, each episode should be treated as a separate infection. Single dose or short course therapy can be used. When reinfections, however, are frequent, which means 3 or more a year, long-term prophylaxis may be indicated. Prophylaxis can be achieved with a low daily dose of several agents, which would include trimethoprim, nitrofurantoin, and trimethoprim sulfamethoxazole. Prophylaxis should continue for at least 6 months. During this time, periodic urine cultures should be obtained. If a symptomatic episode does occur, standard therapy for acute cystitis should be given. If reinfection is associated with sexual intercourse, the risk can be decreased by avoiding after intercourse and by single dose prophylaxis, again, by trimethoprim sulfamethoxazole taken after intercourse. However, if it is due to relapse, recolonization with an original infecting organism accounts only for about 20% of recurrent UTIs. Symptoms that reappear shortly after the completion of a course of therapy suggests either a structural abnormality of the urinary tract involved with the kidneys or chronic bilateral prostatitis, or most common, the cause of recurrent UTIs in males. If obstruction of the urinary tract is present, it should be corrected surgically. If renal calculi are the cause, they need to be removed. Drug therapy is considered progressive. When a relapse occurs in women after short course therapy, a 2-week course of therapy should be tried. If this, however, fails, an additional 4 to 6 weeks of therapy should be tried. If this too is unsuccessful, a long-term therapy of 6 months may be indicated. Drugs employed for long-term therapy of relapse include again trimethoprim sulfamethoxazole, norfloxacin, and cephalexin. Which brings us now to the acute bacterial prostatitis. Acute bacterial prostatitis is defined as the inflammation of the prostate caused by local bacterial infections. Clinical manifestations include high fever, chills, malaise, myalgia, localized pain, and various urinary tract symptoms, which could include dysuria, nocturia, urinary urgency, frequency, or retention. In most cases, about 80%, E. coli is the causative organism. Infections are frequently associated with an indwelling urethral catheter, urethral instrumentation, or transurethral prostatic resection. However, in many patients, the infection has no obvious cause. Bacterial prostatitis responds well to antimicrobial therapy. Because of the local inflammation, antibiotics can readily penetrate to the site of infection. Drug selection and route depend on the causative organism and infection severity. For severe infection with E. coli, treatment starts with an IV agent, followed by 2 to 4 weeks with an oral agent. For severe infections with vancomycin-sensitive E. faecalis, Treatment starts with IV ampicillin sulbactam, followed by 2 to 4 weeks with an oral amoxicillin, levofloxacin, or doxycycline. Urinary tract antiseptics. Two urinary tract antiseptics are available, nitrofurantoin and methenamine. Both are used only for UTIs. These drugs become concentrated in the urine and are active against the common urinary tract pathogens. Neither drug achieves effective antibacterial concentrations in blood or tissues. Nitrofurantoin is a first choice drug for uncomplicated cystitis. So, speaking specifically now on nitrofurantoin, how does it work? Its mechanism of action is a broad spectrum antibacterial drug, producing bacteriostatic effects at low concentrations and bactericidal effects with high concentrations. Therapeutic levels are achieved only in the urine. Nitrofurantoin can cause serious adverse effects. So, nitrofurantoin injures bacteria by damaging its DNA. However, to damage DNA, the drug must first undergo enzymatic conversion to a reactive form. Nitrofurantoin is selectively toxic to bacteria because, unlike mammalian cells, bacteria possess relatively high levels of enzyme need for drug activation. Its antimicrobial spectrum, therefore. Nitrofurantoin is active against a large number of gram-positive and gram-negative bacteria. Susceptible organisms include Staphylococci, Streptococci, Neisseria, and Bacteroid species, and most strains of E. coli. These sensitive bacteria rarely acquire resistance. Organisms that are frequently resistant include Proteus, Pseudomonas, Enterobacter, and the Klebsiella species. Its therapeutic use, therefore. Nitrofurantoin is indicated for acute infections of the lower urinary tract caused by susceptible organisms. In addition, the drug can be used for prophylaxis of recurrent lower UTIs. Nitrofurantoin is not recommended for infections of the upper urinary tract. So, that brings us to its pharmacokinetics, absorption, and distribution. Nitrofurantoin is available in three crystalline forms: microcrystals, macrocrystals, and the monohydrate macrocrystals. The two macrocrystalline forms are absorbed relatively slowly and produce less gastrointestinal distress than the microcrystalline form. All formulas produce equivalent therapeutic effects. Nitrofurantoin is distributed to tissues but only in small amounts. Therapeutic concentrations are achieved only in urine. So that brings us to this table 74.2. Antibiotics specific for treatment of urinary tract infections. It's an outstanding spot to hit pause so you can take a look at all the different medications, their dosage, and their use. Which brings us to the metabolism and excretion. About 2/3 of each dose undergoes metabolic degradation, primarily in the liver. The remaining 1/3 is excreted intact in the urine. Nitrofurantoin achieves a urinary concentration of about 200 micrograms per ml. The drug imparts a harmless brown color to the urine. Patients, however, should be informed of this effect. For two reasons. Nitrofurantoin should not be administered to individuals with renal impairment. Creatinine clearance that is less than 40 ml per minute. First, in the absence of good renal function, levels of nitrofurantoin in the urine are too low to be effective. And second, renal impairment reduces nitrofurantoin's excretion, causing the plasma levels of the drug to rise, thereby posing a risk for systemic toxicity. Which brings us to its adverse effects. The gastrointestinal effects. The most frequent adverse reactions are GI disturbances, anorexia, nausea, vomiting, and diarrhea. These can, however, be minimized by administering nitrofurantoin with milk or with meals, and by reducing the dosage, and by using the macrocrystalline formula. Pulmonary reactions. Nitrofurantoin can induce two kinds of pulmonary reactions: acute and subacute. Your acute reactions, which are the most common, manifest as dyspnea, chest pain, chills, fever, cough, and alveolar infiltrates. These symptoms resolve in 2 to 4 days after discontinuing the drug. Acute pulmonary responses are thought to be hypersensitivity reactions. Patients with a history of these responses should not receive nitrofurantoin again. Your subacute reactions are rare and occur during prolonged treatment. The symptoms usually are dyspnea, cough, and malaise, which usually regresses over weeks to months after nitrofurantoin's withdrawal. However, in some patients, permanent lung damage may occur. Its hematologic effects, therefore. Nitrofurantoin can cause a variety of hematologic reactions, which include agranulocytosis, leukopenia, thrombocytopenia, and megaloblastic anemia. In addition, hemolytic anemia may occur in infants and patients whose red blood cells have an inherited deficiency in glucose 6 phosphate dehydrogenase. Because of this potential for hemolytic anemia in newborns, nitrofurantoin is contraindicated for pregnant women, near term, or for infants younger than 1 month. Peripheral neuropathy, damage to the sensory and motor nerves, is again a serious concern. Demyelinization and nerve degeneration can occur and may be irreversible. Early symptoms include muscle weakness, tingling sensation, and numbness. Patients should be informed about these symptoms and be instructed to report them immediately. Neuropathy is most likely in patients with renal impairment and in those taking nitrofurantoin chronically. Hepatotoxicity. Rarely, nitrofurantoin has caused severe liver injury, manifesting as hepatitis, cholestatic jaundice, and hepatic necrosis. However, deaths have occurred. To reduce this risk, patients need to undergo periodic tests of liver function. Those who develop liver injury should discontinue nitrofurantoin immediately and never use it again. Birth defects. Data are conflicted about the use of nitrofurantoin in pregnancy. Results of National Birth Defect Prevention Study, published in 2009, showed an association between nitrofurantoin and 4 types of birth defects: anophthalmia, hypoplastic left heart syndrome, atrial septal defects, and a cleft lip with cleft palate. However, owing to limitations of the study, a causal relationship has not been established. Because of the possibility of hemolytic anemia, the drug is contraindicated in pregnant patients at term, so between 38 and 42 weeks gestation. Until more is known, it seems prudent to use alternative antibiotics when needed during any gestational age in pregnancy. Which brings us to a spot here at the patient-centered care across the lifespan for drugs for UTIs. It's an excellent spot to hit pause so you can read about it. Central nervous system effects. Nitrofurantoin can cause multiple central nervous system effects, which include headache, vertigo, drowsiness, and nystagmus. All are readily reversible. Which brings us to the methenamine mechanism of action. Methenamine is a prodrug that, under acidic condition, breaks down into ammonia and formaldehyde. The formaldehyde denatures bacterial proteins, causing cell death. For formaldehyde to be released, the urine must be acidic, so a pH of 5.5 or less. Because formaldehyde is not formed at physiologic systemic pH, methenamine is devoid of systemic toxicity. Its antimicrobial spectrum, therefore. Virtually all bacteria is susceptible to formaldehyde. There is no resistance. Certain bacteria can elevate urinary pH, however. Because formaldehyde is not released under alkaline conditions, infections with urea-splitting organisms are often unresponsive. Its therapeutic use. Methenamine is used for chronic infection of the lower urinary tract. However, trimethoprim sulfamethoxazole is preferred. Methenamine is not active against upper urinary tract infections because, again, there is insufficient time for formaldehyde to form as the drug passes through. Methenamine does not prevent UTI associated with catheters. Bringing us to its pharmacokinetics. its absorption and distribution. Methenamine is rapidly absorbed after an oral administration. However, roughly 30% of each dose may be converted to ammonia and formaldehyde in the acidic environment of the stomach. This can be minimized by using the enteric-coated formula. The drug is distributed throughout the total body water. Its excretion, therefore, methenamine is eliminated in the kidneys. Within the urinary tract, about 20% of the drug decomposes to form formaldehyde. Levels of formaldehyde are higher in the bladder. Because formaldehyde generation takes place slowly, and because transit time through the kidney is brief, formaldehyde levels in the kidneys remain subtherapeutic. Ingestion of large volumes of fluid reduces its antibacterial effects by diluting methenamine and raising urinary pH. Poorly metabolized acids have been administered with methenamine in attempts to acidify the urine and thereby increase formaldehyde's formation. However, there is no evidence that these acidic enhances any kind of therapeutic effect. Adverse effects and precautions. Methenamine is relatively safe and generally well tolerated. Gastric distress occurs occasionally, probably from formaldehyde in the stomach. Use of enteric-coated preparations may reduce this effect. Chronic, high-dose therapy can cause bladder irritation, manifested as dysuria, frequent voiding, urinary urgency, proteinuria, and hematuria. Because decomposition of methenamine generates ammonia, the drug is contraindicated for patients with liver dysfunction. Methenamine salts should not be used by patients who have renal impairment because crystalluria may be caused by precipitating the mandylate or hippurate moiety. Other drug interactions. Urinary alkalinizers. Drugs that elevate urinary pH inhibit formaldehyde production and can thereby reduce the antibacterial effects. Patients taking methenamine should not receive alkalinizing agents. And lastly, sulfonamides. Methenamine should not be combined with sulfonamides because formaldehyde forms in insoluble complexes with sulfonamides, thereby posing a risk for urinary tract injury from crystalluria. And that completes our chapter here for today. I thank you as always for listening, and I'll see you at the next chapter. Till then, thank you and take care.